Oh, nearly done. Oh, there we go. So, hi, welcome to today's session. Thanks for joining. I'm Vicky, a doctor at Eastbourne Hospital, and then we also got.
I'm Tess. I'm a doctor at Conquest Hospital.
Lovely, and we'll be doing the second part of our paediatrics series. So we'll be covering a few more topics that we didn't manage to in the other session, because peds is a very big subject, I would say. So I will make a start, as there's lots to cover, but this is recorded, and we will be uploading to various platforms as well. So don't worry, other people can find this as well if they haven't managed to catch it live. So just a quick little summary of who we are. So we're a teaching series aimed at preparing those for finals, but this is obviously relevant for whatever stage you're at as well. And we'll be doing 10 to 15 minutes of timed MCQs at the beginning. We only have 9 MCQs today, actually, but then we also have a quiz bit, so don't worry, there'll be plenty of questions to do. And actually, to be honest, we are kind of coming to the end of this series. I think we may have 1 or 2 more sessions, but this might be, to be honest, one of the last ones we do. And just in time, I think, for some last exams that are going on at the moment. So in terms of what we're going to cover today, so we're going to do a bit of cardiology. So Tess is going to talk to us about, what to do with differentiating causes of shortness of breath, floppy baby, blue baby, and this particular syndrome. I don't want to try and pronounce that. And then we've also got some dermatology questions for you as well. Very useful to go through because they're quite straightforward when you know what the answer is, and very useful to know for exams. And then also like non-blanching rash differential. So that's not just, I suppose, dermatology things, but how other conditions can present with the dermatological presentation as well. And then just some developmental milestones and red flags questions as well. So I'll let Tess take it away with timing it for the MCQs.
Okay, so I think we're going to do a minute a question. And Vicky, I'll just let you know when to change slides. So if we start with the first one. Okay, question 2. Can we have question 2, Vicky?
Sorry, I forgot that you couldn't change the slides. Apologies.
And question 3. Question 4. Question 5, please. Question 6. Question 7. And question 8. And finally, question 9. Okay, we can move on.
Well, Tess, just to let you know, I found a way of making the polls. It actually wasn't as difficult as I thought it was going to be. So we
Okay.
can use a poll in this session. I've got them queued.
Okay.
So
Oh, you've got them queued up. Perfect.
they're queued
Okay.
up. They're ready to go. So
Amazing. Well, do you want to hit the first poll then?
sure. So start polling. Hopefully that's come up for everyone.
Oh, it's even asking me. Let's see if I can remember my answers. Is everyone else seeing the poll? Oh yes, I can see we're getting some answers in the chat, and as in the polls showing up in the chat. Excellent. Okay, so we've got about 2/3 of people thinking it's... Oh no, it's changing. Okay, people are still answering. Okay, looks like the majority of people have gone for C, and we've also got some A and some D. So if we just go to the next slide, Vicky. So it is C, and the things in the question that tell you that, we're going to sort of go over this in a second, but the fact that she's never turned blue makes us think it's an acyanotic condition, which is going to rule out some of our answers. We'll go through which ones. The rubella is a risk factor for pulmonary stenosis and also some of the other conditions. The ejection systolic murmur heard loudest in the pulmonary area does suggest it's a pulmonary stenosis, as does the raised JVP and palpable thrill. For the people that went for A, it's correct. You can get pulmonary stenosis as part of tetralogy of Fallot, but that is usually a cyanotic condition, which is why that's less likely in this case. So if we go on to the next slide, just to sort of quickly review the normal heart anatomy to make sense of the rest of the explanations. Problems with construction of the heart can occur due to infection, maternal drug use, genetic problems, or sort of the environment in the first days of life. If you look, the fetal heart has these two connections. This is just quick revision. It's got the ductus arteriosus and the foramen ovale. That's going to sort of allow mixing of deoxygenated and oxygenated blood. And at birth, you should have decreased pulmonary vascular resistance, which causes a fall in the pressure in the right atrium, causing the foramen ovale between the two atria to close. And then increased blood oxygenation is going to cause a drop in your circulating prostaglandins, which should cause closure of the ductus arteriosus. So it might be that, in utero something's gone wrong, or it might be that this process of closing various holes goes wrong. So if we go on to the next slide, you can broadly group your congenital heart conditions into acyanotic and cyanotic conditions. We're going to look at the acyanotic ones first, and these are broadly where there's a hole between the two sides, but the flow is still going sort of left to right, so things only oxygenated blood is being pumped into the deoxygenated system. You're not getting any of the blue blood into the rest of the body, or if there's a blockage. So overall, your blood is flowing in the right direction, but there might be a shunt or an obstruction that's slowing things down. Okay, so these are acyanotic. Your cyanotic conditions is where deoxygenated blood is making it into the body rather than purely the lungs. These are sort of the more common, in inverted commas, examples that are good to learn for finals. But they're actually very rare in real life and are managed in very specialist centres. Over time, the acyanotic left to right shunts, so the holes, can become right to left shunts because of sort of right-sided hypertrophy. That's when you get Eisenmenger syndrome. So if we go on to the next slide, your main obstructive cardiac lesions are your coarctation, so narrowing of aortic arch, your congenital aortic stenosis, and your congenital pulmonary valve stenosis, which is what we had in the question. These are just sort of pictures so you can see where the different defects are. Okay, so if we go on to the next slide, I've just summarised in this scary looking table key things that can be useful in your MCQs. Less likely that you're going to see a congenital lesion, cardiac lesion in Uroscopes. I'd much more expect it to come up as MCQs. Okay. So coarctation, you've got a narrowing of your aortic arch. The severity of that narrowing is going to determine your symptoms, and it can often be associated with another genetic condition. For example, Turner's syndrome. Things to see in your MCQs are when they say sort of, well, to be honest, all these babies are going to be short of breath and feeding poorly, but the words sort of grey and floppy might make you think of coarctation, or a difference in the blood pressure between the limbs, or an underdeveloped limb that's being supplied by the blood vessels distal to the narrowing. You are going to hear a murmur in many of these cardiac lesions. Can anyone tell me in the chat any different murmurs they'd expect to hear in the conditions on this page? I haven't popped them on purpose. Let me just see if we've got any answer. Yeah, think about what murmurs you might expect to hear in the chat, and I will just carry on talking for a second. So, coarctation can be mild enough that you only need surgery in adulthood, but in really severe cases, you might have to do surgery sort of very early in childhood and use prostaglandin E to keep the ductus arteriosus open to supply sort of the rest of the body. Your congenital AS and PS are going to have quite similar symptoms, which might also include being asymptomatic, but typically you've got your dizziness, your fainting on exertion, in severe cases heart failure within months of birth, and both of them are going to have murmurs heard in different places and can be diagnosed with an echo. Congenital aortic stenosis needs regular monitoring, so echo, ECG, exercise testing, and is eventually going to need probably a balloon valvuloplasty or some other valve replacement. For congenital PS, you can actually watch and wait, but again, they're probably going to need a a balloon, valvuloplasty. Okay, has anyone got any suggestions in the chat for murmurs they might expect to hear? Or are you going to make me tell you? So coarctation is typically a systolic murmur that you hear in the left infraclavicular area and below the left scapula. AS, aortic stenosis, just like adults, you're going to have an ejection systolic crescendo-decrescendo murmur that's loudest in the aortic area that radiates to the carotids. And pulmonary stenosis we had in the question is ejection systolic, loudest in the pulmonary area. Okay, so yeah, I found this table quite useful. If we go on to the next slide. So this is now the other acyanotic conditions, the holes in the heart. So you've got your patent ductus arteriosus, your atrial septal deviation. Do I mean deviation? ASD. What's the D?
Defect?
Defect, thank you. Atrial septal defect and your ventricular septal defect. Sorry guys, it's been a long day on IT. So like we said, usually because the left side of the heart is going to be pumped much more strongly, even though there's a hole, blood is going to go left to right, not right to left, and they're going to stay acyanotic. I'm not going to read out all the information that's on the slides. They'll be available to you later. But basically, the PDA will often spontaneously close, but if it's there beyond a year, probably going to want to intervene. All these kids are going to have, difficulty feeding, poor weight gain, maybe heart failure later in adulthood. When you've got a hole between the two sides of the heart, you're also at risk of strokes. So in the same way that a DVT usually would go to the lungs, they can cross over that hole and end up in the brain. So someone with ASD needs anticoagulation. And then for ASD, you can watch and wait, and if they get symptoms, you do a closure. And it's similar for VSD as well. Does anyone want to throw out the murmurs they might think they could hear in these conditions? If anyone's watching this recorded, it's a good idea to try and test yourself. Write it down and pause the video. So a PDA, a patent ductus arteriosus, would give you a continuous crescendo-decrescendo machinery murmur and a difficult to hear second heart sound. Your atrial septal defect gives you a mid-systolic crescendo-decrescendo murmur that's loudest at the upper left sternal border with a fixed split second heart sound. So you can get a split second heart sound when you're breathing, but this one doesn't change. It's there permanently. It's always a split second heart sound. And then in VSD, you've got a pansystolic murmur that's more prominently heard, again, at the left lower sternal border in the third and fourth intercostal spaces. You can get different types of atrial septal defect. So you can get ostium secundum, which is just there's different parts of your septum. So that's when the septum secundum doesn't fully close. You can get ostium primum, which is when the septum primum doesn't fully close, and that actually causes an atrioventricular septal defect. And then patent foramen ovale is not strictly an ASD, but it's kind of in the same region. So if no one has any questions, someone said machinery murmur for PDA. Absolutely right. So if we go on to question 2. So this is now a baby that's having episodes of distress and feet turning blue. So if people just want to answer in the poll what they think the findings may include. So far people are going for C. So this is now a blue baby, so we're thinking about our cyanotic side of the spectrum. Again, sort of generic symptoms you get when there's a cardiac problem, not feeding well, maybe short of breath, and this baby does have a murmur and clubbing. Okay, so most people have gone for C. A couple of people have gone for B as well. So if we go to the next slide. So this is a case of tetralogy of Fallot, and we're going to go on to look at the 4 parts of the tetralogy. But in this case, only the options in 3 were correct. So there are 2 other things, but I didn't want to give it away by listing 4 things, because that would be obvious with the name tetralogy. So here the murmur that's described is very similar to question 1. It's pulmonary valve stenosis, but this is a blue baby with nail clubbing, history of Down syndrome. So it's a slightly different situation. Slightly tetralogy of Fallot, and VSD is one of the features of that. So if we go on to the next slide. So there are 4 sort of coexisting pathologies in tetralogy of Fallot that result in a right to left shunt. Okay, so these pictures are both showing the same thing. You're going to have a ventricular septal defect, which allows flow between the ventricles, but that alone wouldn't be enough to cause cyanosis. You also have what's called an overriding aorta. So instead of sort of just getting blood from the left ventricle, it's sort of sitting directly over the VSD, so it's getting all that mixed blood going into it. Then you've got pulmonary valve stenosis, which is providing resistance to blood that's sort of in the right ventricle, which means that it was more happy to flow through the VSD because there's less resistance there than there is going through the pulmonary valve. So that's starting to cause our shunting the other way. And then because of all this resistance for the pulmonary valve, because of resistance from the left side, your right side of your heart is going to sort of hypertrophy, and then that's going to be so strong it can push your deoxygenated blood over to the left side of your heart. Okay. The degree of the right to left shunt is actually most affected by the degree of pulmonary stenosis that's present. So that's the single sort of biggest influence on how much there is right to left shunting. If we go on to the next slide, we'll look at the presentation. So you'd hope that it would be picked up very early on antenatal scans or in the NIPE exam if they hear a murmur. But the child may present a little bit later with signs of heart failure, episodes of cyanosis. You can get clubbing, poor feeding, poor weight gain, this pulmonary stenosis murmur, and you can also get TET spells, which is sort of what the question was describing. So these are intermittent periods where the shunt suddenly worsens, causing, symptoms, including cyanosis. And the triggers are basically anything that causes pulmonary resistance to increase or systemic resistance to decrease. And that can include physical exertion, crying, even just waking up. And they'll be very irritable, short of breath, and blue. Okay. The gold standard for diagnosing tetralogy of Fallot is echo. You can also use Doppler flow studies to assess the severity, and a chest x-ray might show sort of a boot-shaped heart because of your right ventricular thickening, but that's not going to be for diagnosis. And then I've popped on some of the risk factors. So there are maternal risk factors, and then also some associated syndromes like Down syndrome, which we had in the question. I think the mum in the question also had diabetes, and it was over 40. So if we go on to the next slide, just to show management very briefly, if we keep the ductus arteriosus open, we're going to send blood to the pulmonary arteries. So we want a prostaglandin infusion, but ultimately we're going to want a total surgical repair, which might involve open heart surgery more than once. If they have the treatment, the surgery, then 90% live into adulthood, but without any treatment, the prognosis is very poor. And for TET spells, if you're sort of faced with one as the new junior doctor, You're going to want to increase their systemic vascular resistance. So little babies, you just pop their knees to their chest, like in the picture, and an older child can squat. Put oxygen on them, call for help, and then you might consider some of the drugs on the screen. But to be honest, by this point you should have a senior around. Okay. So if we just pop onto the next slide, the other cyanotic condition that I really wanted to sort of focus on is TGA, transposition of the great arteries, where you basically have the aorta and the pulmonary trunk attached to the wrong ventricles. So you have two separate circulations that aren't ever joining, so the deoxygenated blood isn't getting oxygenated in the lungs, and you're not getting any... the deoxygenated blood is getting oxygenated in the lungs and then just going around in a closed system. It's never getting to the body, which is fine when the baby's in utero, because the gas and nutrient exchange is happening in the placenta, but it's immediately life-threatening after birth. So the only way they can really survive is if they have a shunt between the two circulations, so a patent ductus arteriosus, an ASD or a VSD. Usually we know about it beforehand because of antenatal ultrasound. Otherwise, they might be born blue or turn blue within a few days. The shunt will initially help compensate, but within a few weeks they're going to get respiratory distress, tachycardia, poor feeding, poor weight gain again, sweating, etc. So initially, what we can do is we can make those shunts a little bit more permanent. So we can do a balloon septostomy to open up the foramen ovale and create our own H receptor defect. But ultimately they're going to need what's called an arterial switch procedure, which is open heart surgery. You put them on cardiopulmonary bypass and you literally just switch the two trunks back. And at that time you'll also correct any kind of ASD or VSD that's present. Okay, and if we go on to question 3, our last cardiology question. So we'll pop the poll up. This is a very good idea, using the polls, Vicky. I'm glad it was easy.
Yeah, it was actually one of the students last week that was showing me one of my questions. So yeah, I was like, oh, it's actually not that difficult.
Yeah. You've put in the chat that PROVE is a way to remember, it's like an acronym for all the defects in tetralogy of Fallot. Very good. Okay, so in terms of question 3, we've got mostly C's, some A's. So this is a case of patent ductus arteriosus, and it's asymptomatic, so I get why people are saying monitoring is fine. And we would do that up to the age of 1 because we hope that it closes spontaneously, and if it's asymptomatic we don't need to intervene yet. But this baby is now more than a year old. It's unlikely to close on its own, so we do need to close it. And if we go on to the next slide, the sort of way to close it is a transcatheter closure. Okay, so this is just from the previous slide. I've just summarised what we did before. So it's asymptomatic, monitor until 1 year, then intervene. So why do we need to intervene? Why can't we just leave it if they're not getting symptoms? I alluded to it earlier. It's the syndrome that was on a very early slide. If we go to the next slide. So it's Eisenmenger syndrome. So this is, I described this earlier, where basically a left to right shunt starts flowing the other way, and you can get cyanosis because of this. And this is because you've had such a long time of extra blood flowing left to right that you've got right-sided cardiac hypertrophy and pulmonary hypertension. And when this pulmonary pressure exceeds the systemic pressure, then blood is going to start flowing the other way. And you're going to get cyanosis, syncope, shortness of breath during exertion, fatigue, chest pain, palpitations. You can also get sudden death and hemoptysis as late signs. And because of their sort of ongoing hypoxia, relative hypoxia, they're going to develop secondary polycythemia. And also you've got your right ventricular failure. So we can prevent all of this happening by fixing the underlying structural defect. But if we get as far as Eisenmenger syndrome, the increased pulmonary vascular resistance and the hypertension are actually irreversible. So we've sort of missed the boat then. You can give supportive treatment, which can include sildenafil for pulmonary hypertension, treating polycythemia if they're symptomatic, which involves phlebotomy to try and lower the hematocrit, volume replacement with normal saline, and iron replacement if needed. They're definitely going to need VT prophylaxis, and they might need, it's recommended to give antibiotic prophylaxis to prevent infective endocarditis. But in severe cases, the only real way to fix the issue is a heart-lung transplant, which carries a very high mortality risk. So if we can prevent us ever getting there, why wouldn't we? Okay, so has anyone got any questions about cardiology, paediatric cardiology, before we move on? That's just been a whistle-stop tour through the acyanotic and cyanotic conditions, how to recognise and treat. Okay, and if any questions that anyone comes up with later, please feel free to pop in the chat. We'll do our best to answer. So if we move on now to question 4 and 5 are my dermatology questions. Okay, so far everyone's gone for C. I'm noticing that I might have put C for most of my questions. Put the right answer on C. I don't think question 5 is, so don't be caught out. Okay, so everyone's agreeing this child can go back to school once all their blisters have crusted over. Can anyone pop in the chat what this is, what this condition is? You all seem to know the management, so does anyone know? Can anyone just write what the condition is? Okay, if we go to the next slide. So it's chickenpox, which I think you all secretly knew, just no one was willing to write in the chat. We're going to do a little fast-paced quiz in a second, which I hope people will be happy to answer, but this is quite a common description of your chickenpox, and they can go back to school once their blisters have crusted over. If we go to question 5, and then we will do our quick run through of the other rashes. So if people can answer the poll and then also write what they think this description is, what this rash is. Okay, looks like we've got mostly D's, a few E's. So if you go to the next slide. So this is non-bullous impetigo, and although fusidic acid is a valid treatment, you would start with the hydrogen peroxide unless sort of unsuitable for any reason. And then if they were systemically unwell, or if it was a bit more widespread than just this area, you might step them up to an oral antibiotic like oral flucloxacillin. Permethrin is for scabies, and the sort of supportive treatment in A is not not super inappropriate, but it's not really going to clear the infection. The infection will clear it usually on its own, but we like to speed the process up because it's very infectious. Okay, so if we go to the next slide. So we now have a series of pictures and descriptions, and I would love it if people would throw ideas out into the chat. It's completely fine to get the answers wrong, but if people just say what they think it is and or what kind of treatment they would give, that can make this more engaging for everyone. So, Vicky, if you pop up the first rash. So if we look at the pictures, and then we think that this has got mouth ulcers and spots and blisters on the palms and soles associated with a low-grade fever and malaise. Has anyone got any suggestions what that could be? If no one answers, I'm going to make Vicky answer all the questions. Hand, foot and mouth. Thank you, Kira. Absolutely. Next slide. So it's a hand, foot and mouth disease caused by the Coxsackie virus, A16. Yeah, absolutely, Sarah, Coxsackie. It's very infectious, so you do need to keep the kids off school, but you don't really need to give them much management, just supportive sort of fluids, paracetamol, ibuprofen, and it's going to improve within 7 to 10 days. Okay, next slide. Okay, to be fair, we've already had this picture, so if we just go to the next slide. So this was our chickenpox picture. I've just popped pictures of what it might look on slightly darker skin as well. So you've got the different stages of the spots with the blistering and the crusting. Malaise, sore throat. It's caused by the varicella zoster virus. It's spread via droplets. And again, the management is usually just supportive. Paracetamol, some cooling lotions. And you keep them off school until it's all crusted over. Which is a beautiful concept. So if we go to the next slide, this is again a rash all over the torso, but it looks a little bit different. You've got sort of flat patches or splotches. And a couple of days earlier, the child might have had some white spots in the inside of their cheeks. The rash started on the head and behind the ears and has spread down the body to include the lower extremities, and they have coryzal symptoms. Has anyone got any suggestions what this might be? Measles, absolutely. Any idea what the white spots are called? Yeah, got another vote for measles, yeah. Koplik spots, absolutely. Smashing it, guys. So if we go to the next slide. Just going back to the pictures as well, it's red on sort of lighter skin, but on darker skin it can look quite brown, or like it's petechiae, so you can mistake it for sort of meningococcus sepsis, etc. So the white spots are called Koplik spots, like we've said. It's caused by an RNA virus called, I've committed to this now, Paramyxoviridae morbillivirus. It's very infectious. It's a notifiable disease. They need to stay off school for 4 days from the onset of the rash and avoid any babies or pregnant women. And again, it's going to resolve on its own, usually within 7 to 10 days. So you can just give them some paracetamol, ibuprofen, and keep them hydrated. 30% of people who get measles might develop a complication. That can include pneumonia, diarrhea, and dehydration. More severe cases, encephalitis, meningitis, hearing or vision loss, and unfortunately, more rare but possible is death. So it's important. That's why we vaccinate against it, but it's usually a self-limiting condition. If we go to the next slide. Anyone have any suggestions for this? I wouldn't have known this, I think, for my finals, but I have seen a case. The key things to look for here in the MCQs are like the dimple in the middle of the spot, the clusters. Molluscum. Oh, someone knows their rashes. Very good. Absolutely, yeah. Okay, so if we go to the next slide. So this is Molluscum contagiosum. It's caused by molluscum virus. It's very infectious. It's spread by skin-to-skin contact, which is why it can start like on one part of the body and then you can spread it to another part of the body. It's important to keep sort of towels and clothing separate because you don't want to spread it around, but you don't have to sort of keep off school. It doesn't make people super sick. So we don't usually need any treatment because it just goes away on its own within 18 months and it's not going to sort of stop them doing their everyday activities like going to work, doing swimming, sports. There are treatments available, but they can be a bit painful and can cause some scarring. So that's why we avoid it in children if we can. We can usually treat older children or adults if it's sort of affecting their quality of life because it's unsightly, or if they're having a weakened immune system. And that can be like liquids and gels applied to the skin or minor procedures like cryotherapy. So that's usually more sort of cosmetic or if they're immunocompromised. It's not usually worth it in children because of the risk of scarring. Next slide. So we have this in the question, one of the questions earlier. I particularly like the description of them being like cornflakes. And these children are usually well. It can look a bit different if you've got darker skin. What did I call this in the question? And we did talk about treatment actually. Impetigo, absolutely. So next slide. I'm going to just summarise. So there's two types of impetigo. The more common one is non-bullous impetigo. The whole sort of impetigo, both types, is caused by either Staph aureus or group A beta hemolytic strep. It's spread by skin-to-skin contact and it's highly contagious, as all of these have been, I think, so far. So similar to chickenpox, you keep them off school until their sores are full healed, or because you can give antibiotics 48 hours after starting antibiotics. They are okay to go back. The actual first line treatment is topical antiseptic, like a hydrogen peroxide cream, but you can give a topical antibiotic instead or in addition, and that just helps reduce the length of the illness and reduce the spread. It would improve on its own without treatment as well. And like we said earlier, if they've got a more widespread infection or they're systemically unwell or at risk of complication because of other conditions, we can give an oral antibiotic like flucloxacillin. The other type of impetigo is bullous impetigo. Does anyone know sort of how that differs, what that means? If we go to the next slide, Vicky. So this is much less common. Usually affects the trunk more, or the sort of intertriginous areas, so like sort of armpits and groin. And you get these often painful fluid-filled blisters that burst after a few days and leave a more sort of pale yellow crust. They don't get that golden colour that you typically hear about in the non-bullous impetigo. This one can also occur on your buccal membranes and often has systemic symptoms, fever, diarrhea, malaise, etc. Okay, so next slide. So I had, on my 5th year placement, I had a patient with this condition, and I saw the mother had already sent in a picture, and I literally went on Google and typed in like ring-shaped rash because I didn't know what it was. Does anyone have any guesses for what this might be? Ringworm, absolutely. In hindsight, it was obvious, but I needed Google that day. So if we go on to the next slide. So we've got our red ring, usually with a central clearing. This might be silvery as well, itchy, scaly, raised, and it's caused by fungal infection. So unsurprisingly, we treat it with a topical antifungal, or if it's more severe, we can do an oral antifungal. It's called tinea corporis, which just means dermatophyte infection of sort of the body, ringworm. You've also got tinea capitis, which is scalp ringworm, tinea unguium, which is nail infection, or tinea pedis, which is athlete's foot. So it's just all dermatophyte infections of different areas. If we go on to the next picture, we're getting near the end of the rashes, I promise. So this is little small red blotches and blisters on very young children and older adults. It might be on the soles of their feet. Other sort of adults and not so young children might have it between their fingers and in sort of other skin folds. It's very itchy and worse at night and can affect a whole family. And I can see Kira has already suggested scabies, which is absolutely right. For any bonus points, can anyone tell me the treatment for scabies? I did mention it earlier, if anyone can remember. Permethrin, absolutely. Spot on. So if we go to the next slide. So it's caused by these little mites that burrow into your skin, especially the skin folds. It can be spread by skin to skin spread, and also sort of from affected like towels and bedding. And you treat it with permethrin, or if it's a very young infant, you give them sulfur, 6% in petroleum. Very impressed with you guys. You've got good knowledge. If we go on to the next picture. So a rapidly appearing red rash on both cheeks, and that might be followed up by a rash on the trunk a few days later. It can be seen in other ages too, but the sort of most common ones are 6 to 10. Anyone got any suggestions what they think this is? Slap cheek syndrome, absolutely. If we go on to the next slide. So slap cheek syndrome is caused by parvovirus B19. It's also called like fifth disease or erythema infectiosum. And by the time you have a rash, you're actually no longer contagious. So if you're systemically well, you don't have to stay off work or school. It usually just requires supportive treatment and hygiene measures and clears up on its own. But if you're immunocompromised or pregnant, or if you have a hematological condition that predisposes you to anemia, then you're more at risk of complications. The main one is aplastic anemia. So in those at-risk patients, you should confirm the diagnosis with serology and then check your full blood count and reticulocytes. Other complications include encephalitis, meningitis, fetal death, unfortunately, if a pregnant woman gets it, and more rarely things like hepatitis, nephritis, etc. If we go on to the next slide. I think there's like 3 more rashes left. So this one is one that was in the news, I think, like last year or the year before. Your sandpaper rash starts on your torso, then spreads out to your arms and your cheeks and your very red mouth that you might call strawberry tongue. Scarlet fever, yeah, people are coming in with that. Great answer. So you usually have a sore throat, fever, headache. It's associated, if we go to the next slide, it's associated with tonsillitis usually. It's caused by group A strep. So group A strep is a bacteria. Most of us will have been exposed to it, and a lot of us actually carry it without having any problems, but young children might not have been exposed to it, especially because of COVID, so they can be more symptomatic. The most typical thing you get is strep throat, so sore throat and fever, but some children are going to go on who get the group A strep are going to go on to develop scarlet fever, which has these symptoms. These children usually need antibiotic treatment, and there are potential complications with this condition, so parents need to be given safety netting information, which we're going to go over on the next slide. They need to be kept off school for 24 hours after starting the antibiotics, and it is a notifiable disease. Okay, so if we go on to the next slide, these are just a couple of things that we might mention to parents. Basically, they're at risk of breathing problems, dehydration. Acute rheumatic fever is one complication, so sort of sudden joint pain. More rarely, necrotizing fasciitis, and you can also get post-strep glomerulitis a few weeks later. So the 999 things, I think they're quite obvious. Like, if your child stops breathing or is going blue, call 999. And then the other stuff is sort of if they're, not having their normal oral intake, if they're a very young baby with a high temperature, sleepy, irritable, drowsy, all this kind of thing, you need an urgent same-day appointment. Okay, and then if we go to the next slide. So this is an erythematous macular rash. Looks a little bit like the measles one, but it's milder, less red. The skin might actually feel a bit bumpy. And this one starts on the face, spreads to the rest of the body, and might be associated with mild fever, joint pain, and lymphadenopathy. Does anyone have any ideas what it could be? It's another part of the MMR vaccine, if that helps anyone. So if we go to the next slide, it's rubella. Unsurprisingly, that's caused by the rubella virus. It's spread by respiratory droplets, and actually you get symptoms 2 weeks after you've been exposed, which is a bit unfortunate. It's another notifiable disease. You need to stay off school for at least 5 days and avoid pregnant women, because you're at risk of causing congenital rubella syndrome if you get it when you're pregnant. That's a triad of deafness, blindness, and congenital heart disease. So it can be devastating. That's why pregnant women are offered the vaccine. In sort of non-pregnant people, other rare complications include a thrombocytopenia and encephalitis, but it's usually self-limiting, so you just need to stay away from people for 5 days. And then I think my last rash is this one. So now we've got, again, ring-shaped lesions, but they're more target lesions, so they've got a dark centre and then a ring. This one starts peripherally and spreads centrally. Any ideas what this could be? Okay, if we go to the next slide. So this is an erythema multiforme. Oh, we got a correct answer in the chat within seconds, so I'll allow that. So this is a hypersensitivity reaction, usually caused by an infection. It can be viral or bacterial, in particular something like HSV or EBV, but can also be caused by some vaccines and medicines, including NSAIDs, antibiotics, and statins and anti-epileptics. The treatment is usually sort of emollients, and then hope that it improves within 2 to 6 weeks. Okay. If we go on to the next slide. So these are some other sort of derm conditions. Didn't cover eczema and psoriasis, acne, because I hope everyone's familiar with that by now. Other sort of specific PEDS ones to look at would be the staphylococcal scalded skin syndrome, caused by bacterial toxins. The differentials for erythema nodosum, because it can be a sign of something serious underlying. And then the other viral exanthems, so red conditions, so Duke's disease. Parvovirus B19 shouldn't be on there. That's slapdick syndrome. And roseola infantum. The picture on the screen is eczema hepaticum, so that's when you get your herpes virus infection of your eczema if you've got breaks in your skin. So that's a sort of a condition to look out for. You can also get cellulitis associated with eczema if there's breaks in the skin and bugs are getting in. So those are important ones to think about in your exams. Okay, I'm going to hand over to Vicky now, who's going to take you through a non-blanching rash for a change.
Hello. So yes, over to my section. So we'll start off then with this question here. So if you can cast your minds back to when you first saw this, I'll start the poll. Okay, got a bit of a split at the moment. Give it another few seconds. Anyone else want to give it a shot? Okay, I feel like that's enough time. So yes, well done to, I think, most of those who answered D, but I also see where that person who answered C is coming from. So yes, the answer in this case is HSP. I'm just going to abbreviate to HSP. So let's go through why that is the case. So the reason why I actually brought this topic up is because I think it's important to think about differentials of a non-blanching rash, because obviously the most worrying one out of all of these differentials would be something like a meningococcal septicemia. And I think being able to distinguish what could be causing the rash, and especially when it's non-blanching, is really, really important, so you feel confident in your diagnosis that you're managing the patient safely. So hopefully in the STEM you picked up the fact that they're basically systemically well. That's what I was trying to get at with, he's been feeling well but awake and alert, observation shows hemodynamically stable, so this boy is well, even though he says he's been feeling unwell. And the key bit about the rash is, so yes, although it is non-blanching, and then that's a whole lot of different differentials there, but I think it's mainly that combined with the fact he's systemically well and the location of the rash. So typically HSP presents on the lower limbs and buttocks. If I was being extra nice, I could have given you an image, and that probably would have sold it to you a bit more as well. And you might get that in the exam as well. And then also the joint pain as well. So like an ache in the ankles and knees, very common in HSP as well. Other things that you could get, which I didn't put in this question, are you can get the kidney involvement. So his urinalysis does show like it may be starting to affect his kidney slightly, with a bit of blood and protein there, but not quite in the region of sort of nephritic syndrome. And you can see as well from his bloods that his urea and creatinine are within range, so no acute kidney injury there. So yes, all of this to me points towards HSP in this case. However, let's go through the other differentials. So starting from the top, SLE. So yes, that can present with a vasculitis type rash as well, but typically not in the area that is stated in this question. And also typically you might have a longer history of general health issues. I think, to suddenly present with a rash and it presents as SLE would be quite rare, and also the age range as well in this case, a bit on the young side to be developing SLE. I just think it's probably unlikely with the short history here and everything else that's going on. And then B, we kind of covered this. So if they got to the stage where they had, quite visible purpuric rash that's non-blanching, or, quite all over their body, they're going to be quite unwell at this point. It's not actually a very early sign of sepsis. So hopefully we'd have been able to pick up slightly earlier with the observations going off, so high temperature, neck stiffness, all those other signs of a meningitis, which is turned into maybe a sepsis as well. So yeah, that makes it unlikely, seeing as he's systemically well. And the hemolytic uremic syndrome. So this is quite interesting. I have to revise a little bit to remind myself of what this was. So basically, it's a triad of microangiopathic hemolytic uremia, an AKI, and thrombocytopenia. So if you just remember that if the platelets are normal, this is probably more likely to be HSP because the low platelets aren't a feature of the HSP here. In HUS and the option E as well, you're going to get low platelets. There's also no AKI in this case. I suppose you could and couldn't get an AKI in HSP as well because it does affect the kidneys, but typically renal function is preserved in HSP. And yes, so it's a tricky one. I know it's maybe not loads of things to differentiate, but I think maybe just go off the platelets by themselves. And also the rash tends maybe not to be as in the location that is described in this question, and also it's more like petechiae rather than a purpuric rash. And I'll go through some pictures to show you the difference between it. It's mainly the size. So petechiae are a bit smaller. And HUS typically occurs after an E. coli infection. So actually an additional thing that you're going to get here is probably some bloody diarrhea. You can get abdominal pain as well in both C and D, but I think it's going to be more of a prominent feature in the HUS as well. So it's a tricky question, actually, dissecting this. And then just going down to the last option, ITP. So this basically happens when a purpuric rash occurs because of low platelets. So look here, the platelets are normal, and basically that results in a purpuric rash. It usually follows a viral infection, and you're not really going to get, again, the type of rash that you're getting here and in the location, and also the other sort of achy joints. Again, a tricky one, and the low platelets as well. That's another differentiating factor. So let's go through HSP in a bit more detail. So HSP is a type of vasculitis. And as soon as you see a purpuric rash affecting the lower limbs and buttocks, and you see that systemically well, just have this in the back of your mind as a differential. So the reason why you develop this rash is because you get sort of IgA and complement components deposited in the vessel walls, leading to inflammation. And this most commonly happens in children, and especially between the ages of 2 to 11. The actual mechanism behind it is still unclear, but there are some risk factors. So can precede a viral infection or a upper respiratory tract infection. The infection would come before it, and actually typically happens more commonly in boys. In terms of common symptoms and signs that you're going to see, so the purpuric rash and that distribution is a big hint. Joint pain is also very, very common. You may get abdominal pain, and signs that it's starting to affect the kidney are things like the frothy urine, and that would be because there's large amounts of protein in there, and this can lead to sort of nephritis. And then eventually, if you're seeing more than 2+ protein on the urine dipstick, they may have a degree of nephrotic syndrome and therefore some edema as well, sort of around the eyes. And you may also get hematuria, again, due to the renal involvement. You may also have a sort of low-grade fever as well, but generally they're not going to be that unwell systemically. In terms of investigations you can do, so mostly you can actually diagnose this clinically, but obviously I think any child with this type of rash, you still just want to keep your differentials open, so just double check their vital signs, things like their blood pressure, urinalysis, basic bloods, and then you can send the urine microscopy for sort of further testing there. In cases where the child is getting sort of severe abdominal pain, you're probably going to want to think, is there anything else going on here? Especially maybe they might start to develop bloody diarrhea as well. So just react to that and maybe consider imaging like an ultrasound scan. And then in terms of renal involvement, it usually tends to settle by itself, but you may need to investigate it further with a biopsy, but you'd have that under specialist guidance. So in terms of management, it's usually going to spontaneously resolve with supportive care, paracetamol, may consider steroids. In terms of the follow-up, children need regular urine dip and blood pressure monitoring for 6 months after diagnosis. In terms of how frequently that happens, that sort of varies trust by trust. But yes, they typically be monitored for 6 months, because you can get sort of a relapse of the condition. You can also get renal failure. It is rare, and nephrotic syndrome as well. So yes, just be aware. And let's just go through non-blanching rash as a whole topic here. So in terms of what makes it non-blanching, so if I go to the next slide first. So non-blanching means that if you sort of press on it, it doesn't disappear. So like the example here with a clear glass, if you've pressed on the rash, it's still there. It's non-blanching. And you can get sort of petechiae, so like I was saying, sort of less than 5 millimeters diameter, purpura just a bit bigger, and then gosh, I can't pronounce any of these words. The last bit there is more like a bruise, so that's really, really quite large. And then here you can see on the picture to the right the difference on the same picture between the purpura and petechiae. So other causes of non-blanching rashes, which you're going to rule in and rule out sort of depending on the associated symptoms. So we've been through a lot of these already, so I won't cover the first 4, but the last 2, so even just sort of forceful coughing can cause these type of rashes. Probably not as significant as you'd get in some of the further up conditions, but certainly you could get petechiae from coughing. And then always have in the back of your mind non-accidental injury as well, depending on the location of it and the pattern of it. Always seek senior advice in that case if you're not sure and you are suspecting a safeguarding case as well. So do just have that in the back of your mind. This is just a little diagram from Don't Forget the Bubbles. Definitely an excellent website to seek more information from. But yeah, this is just sort of categorizing them again. So you get infection causes, mechanical causes, hematological causes, and vascular causes. So just have them in the back of your mind. And then actually I've got very helpful, guidelines from, I think this is from Bart's Hospital. It's one of a really good guidelines. So just always have in the back of mind, are they unwell? Do they seem septic? If yes, treat as the meningococcal sepsis. If they're well and they have all these key features of HSP, sort of joint pain, abdominal pain, and the purpura on the lower limbs and buttocks, you're going to treat as HSP. And if no, you can see this guideline has a very low threshold of just treating this as sepsis. And then if you don't have the big sort of purpura and it's more like petechiae size of rash, it takes you through other things you can think about. So I couldn't fit it all on one slide, but I'll move on to the next bit here. So there's other differentials here. So if you're seeing low platelets, think ITP, HUS, other infections, malignancy as well. So actually key things to remember are they unwell? What is the distribution of the rash, and is it purpuric? If it's petechial, do they have a low platelets? And then it sort of leads you down these different ways of thinking. If you want to actually get a copy of this guideline, you can go on Don't Forget the Bubbles, non-blanching rash, and I think they actually have it on there as well. That's where I got it from. So moving on to question 7. So I'm just going to pop the pop the poll up. There we go. Give it a go. Any takers for this question? Hopefully it's a bit more straightforward than the previous question. Okay, I'm getting a resounding agreement with the answer to this. So yeah, well done. 100% of you got the right answer there. So yes, correct. So you didn't fall for the trap of not reading the questions. Exactly which of the following would you not expect the baby to do yet? So exactly that would be option C. And the rest you would all expect a 10-month-old to have done by now. So moving on to this lovely table here. So I think, to be honest, with developmental milestones, it's really good one to just know the key development sort of milestones, because in the exam it can be quite a straightforward question, easy marks, because it typically is sort of a right or a wrong. Although I think depending on the source that you use, they may vary by like a month or so in terms of like when you're able to make a tower of 2 bricks or 3 bricks. So I think when they give you these sorts of questions, they will be fairly obvious. It'd be a bit mean to sort of have a difference between 12 and 13 months, for example. So just have a sort of general idea in your head of things like, I think typically the earlier developmental milestones are a bit easier to differentiate between. And yeah, so I was make a table like this. You can screenshot this. I'm pretty sure I just got this off the MRCPCH website. So if you just have some links at the end, so you can type this in and it's available for you to look at, and just have an idea of some key ones. And I'll run through, I think what's important as well to know is when to sort of worry and what months are the sort of red flag months to be doing things by. And another important point as well is to remember to correct for gestational age. So if you get a premature baby and they may not, they may not be achieving things at the same time, because you need to then correct for the gestational age. And you typically do that up until 2 years of age that you'd correct. Yes. So yeah, just have a little look at this. And actually, I was listening to a podcast about this just to remind myself about the developmental milestones. And I think an interesting way of trying to remember all of these is to like formulate your own story. So the pediatrician in this podcast was saying you can like liken it to waking up from an alarm clock in the morning. So you like wake up at 6, you start to grimace, and then you'd like turn around, reach for the alarm clock. So it's quite an interesting way of like thinking about it. I wish I'd probably known about that when I was revising. So maybe thinking of a way to make it easier to remember, because I know it is a bit overwhelming trying to look at this table and try and remember it all. But I think it is worth it for the ease of marks, and it may come up, I suppose, in your skills as well. Oh, what was the podcast? So it was the Great Ormond Street podcast, and it's the MRCPCH. I don't know if I'm pronouncing that properly. It's basically the pediatric exam podcast. So some of the stuff is higher level than you'll need to know for your exam, but I think it's quite a easy listen, to be honest. It's not too difficult to understand. And yeah, the one on developmental milestones is pretty good. So have a listen if you want to know more. Okay. And then moving on to question 8, I'll pop the poll in the chat. Excellent. Again, this is a fairly straightforward one, so I'm glad that you guys everyone who answered is getting this right. Exactly, well done. So yeah, 18 months is correct, and that's when you start worrying if they've not started walking by. So this brings up the topic of developmental delay. So developmental delay is a broad term defining delay in any of the 4 developmental areas. So, sorry, I didn't actually explain that very well in the previous topic, but yeah, just to go through then. So yeah, we've got gross motor, fine motor and visual, speech and language, and social. So that's what is meant by that. And in terms of, you can also get global developmental delay. That doesn't mean developmental delay in all of those domains. It can just be in sort of 2 or more. So you could just have in 2 areas, and that would still be global. I've duplicated the slide. Oops. And then in terms of differentials, so it's quite a broad question if you say, what could be causing developmental delay? So many different things. And this is the way I think I sort of borrowed this off Geeky Medics. So this is the way they categorized it. So you can get prenatal intrinsic, prenatal extrinsic. So intrinsic, I suppose, is genetic things that you can't really sort of control. I suppose extrinsic would be sort of any infections or teratogens such as alcohol. To get perinatal, so during the birth, and then postnatal as well, so what happens after. And I think just have a broad range of differentials in your mind. I think a classic one that they like to ask about is things that would indicate maybe cerebral palsy. I'll go through that in just a second. But yeah, sometimes no cause is found at all, and it can be because of fairly benign things, such as maybe if you're growing up in a multilingual home, your language may develop a bit slower because you're actually developing two different languages at the same time, but eventually you will excel and catch up with language development. And then other things like neglect as well can affect your development and engagement, especially the social interaction side of things. So have those as well in the back of your mind. In terms of investigations you can do, I suppose initially they might present in the primary care setting, but then you refer to a paediatrician, as it is a really difficult area to navigate, and you're going to need other specialists as well, so not just the paediatrician, but audiologist, physios, etc. Lots of people involved in diagnosing these. But a history, examination, bloods, MDT approach, and then other investigations like genetic testing and all sorts of other testing, depending on what your differentials are, which can be quite broad. And this is just an example of some hospital guidelines. They're going to vary, I suppose, depending on the trust. But just so you're aware, this is what you may consider. This is another nice table. So yes, I think just to remember key things like I think walking one is useful to know about. Also communication. So if you're not starting to babble by 6 months, and other bits and bobs. But this is basically just a good overall table. And then I've got some more specific ones here. So with the social side of things, if you're not smiling by 10 weeks, that's a red flag. Gross motor, if you're not sitting unsupported by 12 months, not walking by 18 months, that's a red flag. Fine motor, showing hand preference before 12 months. And then speech and language, not knowing 2 to 6 words by 18 months. And then also regression at any age is a red flag. So if you were able to do something and then suddenly you're not, then that's also a red flag, which would cause concern for referral. So I think things like showing hand preference before 12 months, that's, I suppose, an examinable point. And you could say that's quite indicative of cerebral palsy. And then I suppose any issues with social side of things could indicate autism as well. I think those are two type of developmental delays that they'd like to examine on. Another one, which is coming up in just a sec, is also another examinable topic which could present in developmental delay. So without further ado, let's move on to the last question of the night. So I'm going to pop the poll in there, give it a go. I'm fairly sure actually that this is completely based on the question I got in my exam. So I think it's a fairly examinable question. I'll give it another minute or so, a few seconds. Anyone else want to give this question a go? Okay. Ooh, getting a bit of a split here. So I think the key word here is initial investigation. So for 62% of you, yes, you are correct. It is a creatine kinase. And basically, I think all of the answers here are correct. in a way, as in terms of investigations you would do. Because in this case, I hope we've all picked up on it, that the picture over there shows, a Gower sign. So this child is really struggling with getting up onto his feet. And this typical pattern of sort of using your arms and then lifting yourself up like that shows sort of proximal weakness there. This is Gower sign, indicative of a muscular dystrophy, probably at this age, more of a Duchenne's. The history as well here is becoming increasingly clumsy. So I think we're all on the same page that this is a muscular dystrophy, likely Duchenne's. So the first test you would do is a creatine kinase. It's not the only test you do, but it's, especially if you're in a GP setting as well, this is probably the most appropriate one to start off with, at least. All the rest of them you would do eventually. Some you would probably do earlier than others. Lung function tests and echo, those sorts of things may come a bit later on down the line, as this might be quite early stages of Duchenne's. But yes, definitely genetic analysis as well. But that, I think, if we're thinking about the initial investigation, CK would trump the rest of the options there. And let's go through why CK is important to test. But first, let's just explore muscular dystrophy as a topic. So it's a group of inherited disorders characterized by progressive muscle weakness and wasting. So the two most common are Duchenne's and Becker's muscular dystrophy. And the reason why they affect your muscles are because there are mutations in the genes which are responsible for production of proteins, which are key to muscle development, i.e. dystrophin, and with those mutations, it basically results in progressive muscle degeneration. In Duchenne's itself, you don't get any dystrophin production whatsoever, so that is why actually it's quite a quick progression, I think, with Duchenne's versus Becker's. So yes, in terms of what actually causes it, so both diseases are examples of X-linked recessive conditions. So that is why females will not be really affected by it compared to males, because females have 2 copies of the X chromosome, whereas males only have 1. And it occurs, like I said, mainly a mutation in the dystrophin gene, but sometimes it can also, and these mutations can sometimes be spontaneous. You may not have just got it from your parent. And then in terms of presenting features, so progressive weakness, starting proximally, then moving more distally, and then you might get delayed milestones. That's why it relates to the previous topic. If you see a child who's really struggling with the walking side of things, and maybe they are trying to walk, but their gait is very clumsy, then just have this as in the back of your mind as a differential. In terms of examination, so you're going to find, like I said, weakness. You may get sort of calf pseudohypertrophy. So they might appear actually quite big, these calves, but it's actually the fat and tissue replacing the muscle tissue. You might get a sort of waddling gait, tiptoe walking, Gower sign, like shown in that picture. And it might affect your reflexes, might give you flat feet, difficulty, inability to squat. In terms of diagnosis, like I said, creatine kinase would be your first go-to, and it's more accurate the earlier on you do it. And that's because, so it's an enzyme which leaks out of damaged muscle cells. It's typically elevated from birth, peaks at around the age of 2, and then it steadily declines due to progressive muscle wasting. So you would hopefully have already diagnosed it by then, but if they are already at the point where they're wheelchair bound, you may not actually get a very high creatine kinase level to show that they have the disease, because by that point, all the creatine kinase is probably wasted away. Other things you do: genetic analysis, muscle biopsy, examination findings, electromyography, ECG, echo, lung function tests. Those are important because the heart and the lungs can be affected as well. It's going to be a multidisciplinary team approach. So in early young stages, steroids can help with managing maintaining the function of walking for a little bit longer, physiotherapy, Vit D and calcium, and other sort of prosthetics which might help with the walking as well. However, eventually it will leave them wheelchair bound. They'll need to maybe get orthopedics involved, cardiology and respiratory surveillance, and then ultimately advanced care planning, especially in Duchenne's, which happens earlier on and is more severe. So in terms of prognosis, Duchenne patients usually become wheelchair bound by the age of 12, and death can happen fairly early on. Becker's is similar, but tends to happen later and milder, and less severe than Duchenne's. So that brings us to the end of this session. So let us know if you have any questions. I'll pop the feedback link, so sending the feedback in there. These are a bunch of resources that we either use during the session to actually make the slides, or things that we'd used during our revision. Special highlight to don't forget the bubbles for the non-blanching purpuric rash section. There's a really good page on that. And then, like I said, the Gosh podcast as well, which is a really good episode on the milestones, but other paediatric topics as well. So hope that was useful. And remember feedback, please. Thanks for listening. And there's our social media as well. We'll hang around for another minute or so. Yes, good luck with any upcoming exams. If you have them coming up, you'll smash it. Well done for sticking with the revision sessions. I recognise a few names have been coming frequently, so good luck. Okie doke. So if there are no questions at this point, just continue to fill in the feedback form if possible. And like I said, best of luck. And you can always still contact us, even though we're probably not running as many sessions at the moment. We will probably be doing some prepare for the F1 series as well, maybe a bit early for some of you guys. And we may have one or two more revision sessions, but I know exams are wrapping up soon. But thanks for coming and attending.